Good morning, good afternoon, or good evening, distinguished colleagues. I'm very happy to welcome all of you at our conference today. Today, we have scheduled several extremely interesting presentations. This conference will be carried out in a very interesting format for us. It's a very first experience for us, very first experience in organization of international webinar. And it is very important that this is a very first experience with our colleagues from China. I'm not going to take too much of your attention, and let me introduce a colleague of ours who is going to be a moderator today. Our moderator is Professor Shalva Gvetadze. Shalva Gvetadze. Shalva is name, Gvetadze is surname. He is very new in oncology, but he is very well known in this area, is maxillofacial surgery. He had his PhD in Blokhin Institution, #1 oncology institution of Russia. And after PhD, he has been working for 4 years in the 9th People's Hospital in Shanghai. For 4 years, and he has received very interesting experience in Shanghai clinic. We would be happy to get feedback from him to find out what is the experience of our Chinese colleagues. And running ahead, I can tell you that he was fantastically amazed, because he said that is fantastic level of giving care to people in China. And today, Dr. Gvenadze is going to be the moderator. He would be the bridge between Russian and Chinese audience. Shalva, take the mic. Well, Dr. Mudunov, thank you very much for your support. Thank you very much for your interest to organize this type of conference. And to me, it is really a great honor to introduce to you and to our big audience very famous Chinese colleagues, global experts, very famous experts, surgeons from 9th People's Hospital in Shanghai. These are my teachers in China. These are people who influenced me greatly, and due to them, I got some experience, a lot of learning from Chinese university. First of all, this is Professor Jiang and Professor Jiang Chile. And now I'm going to introduce Professor Jiang, who is Vice Director of Oral and Maxillofacial Head Neck Oncology Department of 9th People's Hospital. Also, he is the chair of the coordinating group of plastic and reconstructive surgery of Chinese Association of and also director of division of head and neck surgery, Chinese Society of Plastic Reconstructive Surgery, Chinese Association of Rehabilitation Medicine. Professor Suen will share his experience today, how they perform reconstructive surgery in China, and also he will enlighten prospective ways how we can improve the quality of reconstructions of CMF. Our second expert today, Professor Jiang Chile, who is Vice Director of the Department of Oral and Cranial Maxillofacial Surgery, 9th People's Hospital. He is also the chair of Chinese Society of OMFS, Plastic and Reconstructive Surgery. He is Executive Secretary of this society. He is also famous, not only in China, but also in Asia. And he is one of the global experts in the world, and he one of the pioneers to implement and active use of digital methods of 3D planning and intra-op navigation. In his presentation, he will talk about the opportunities which are given by modern digital technologies in different disciplines of maxillofacial surgery and generally in the surgery of head and neck. And now I am happy to give the floor to Professor Swen.
Professor Swen?
Professor Swen, please speak up.
Yes.
The floor is yours.
Welcome for your greeting word.
You can say your welcoming words.
Good afternoon, distinguished Professor Ali Mounonov, ladies and gentlemen, and all colleagues. At this special time of wonderful weekend on the internet, we are here getting together. It's a great pleasure for me to join this international medical scientific online conference. Thanks a lot, Professor Ali Mounonov and Shawa. Special thanks to Shawa, prepare very well and organized this online meeting. The friendship between us has a long history. Despite the impact of new coronavirus, we cannot hold an offline meeting face-to-face. Fortunately, we can communicate online. I hope this online conference will achieve completely success. And I will sincerely invite our Russian friends to visit Shanghai, especially visiting Nice People's Hospital in the future. Thank you.
Спасибо, Professor Swen.
Thank you very much, Professor Swen. Thank you very much for very nice and warm words. We are always happy to hear and see you in Russia at any place, at any town. You are also very welcome to Russia. Professor Jiang?
Okay, good. Good afternoon. We can say good afternoon in Shanghai, right? But now in Russia, it's in the morning, right? Okay, it's very happy and my honor to be invited in the international conference online. I think it's the first time we meet Professor Ali, and looks very handsome, Professor, right? And we will have a lot of contact, a lot of cooperation in the future. I think even the COVID-19 stopped our distance and stopped our conference or contact face-to-face, but it never stopped our cooperation and never stopped the academic cooperation in the future. So we hope we can have more and more interference or more and more cooperate in the area of oral maxillofacial surgery. Once again, thanks for the invitation. Thanks.
Thank you very much. Thank you.
Спасибо, что приняли наше предложение.
Thank you very much for accepting our invitation. Thank you very much for finding time. So, we finished with introduction and welcoming, and now we can move directly to the scientific program of our forum. And the first speaker today is our host, our main organizer, Professor Ali Mounonov, and we are happy to give the floor to him. Please share your screen and please start speaking. Well, thank you very much, dear colleagues. From my side, I also would like to express gratitude to our Chinese colleagues for finding time, finding opportunity to participate in our forum today. And I hope today we will have very fruitful discussion. And we are planning to discuss very many different interesting issues in 3D planning of CMF, P&R surgeries in patients with different pathologies of head and neck. So now I would like to share my screen now.
Моя демонстрация будет посвящена,
My presentation would be devoted to very simple, on the one hand, things, simple things like reconstruction in head and neck in patients with different tumors. But we all know all those specialists who deal with plastic and reconstructive surgery in CMF, you know how difficult it is to plan, how difficult it is to plan such reconstructive stages. And it takes really a lot of time during the surgery. Now let me say a few words what is available in our portfolio, in surgical portfolio, for the planning of such reconstructive surgeries. We all know that there are lots of standard products that help us in 3D regimen. This is software, and this software help us to plan the volume of defect in CMF, and also it helps us to plan the reconstructive stage. Here on this picture, you can see modern surgical 3D virtual planning technologies. So these are mandible defects using fibula transplants, and this method is very well known. Now about different fixation elements during reconstructive stages in mandible defects. Again, this is already very big experience accumulated in the world about fixating plates and other devices. And currently in the world, you can appreciate very many types of reconstructive plates. Specifically here, I'm showing most advanced, most modern versions, starting from the point that there are attempts to replace mandibular defects using synthetic material, which is here, titanium construction, hydroxyapatite, and also combined options of mandibular defect replacement using mesh implants, titanium meshes, hoping that this defect will also keep some bone material here. It could be autogenic or maybe even allogenic in this basket, and then hopefully this bone material, bone chips later on could be integrated so the new bone can develop here, and this is how it will be possible to reconstruct mandibular defects. But we all know that there are a number of problems and limitations here, and specifically any foreign material in mandibular area or maxillary area sooner or later may lead to the rejection, to the exposure and rejection. And actually it does not depend, for example, this fixating plate, whether it's put independently or it's put on the autograft. And the rate of plate exposure, rate of complication is seen almost in half of the cases, approximately 50%. Yes, there are successful outcomes, and there is even experience of using these plates for years, for decades. So they wear them for many years, but still almost half of the patients face the problem. There is either destruction or exposure of the plate. More elegant solution here is presented here. These are mini plates for facial reconstruction, mini plates. The main idea here is to minimize the amount of metal which is inserted in the reconstruction area to avoid metal rejection. Keeping in mind, even if metal is inert, still metal can be rejected. And this rejection rate is pretty high when patients have combined treatment, including radiotherapy. But even in mini plates, we have a number of disadvantages we are going to talk about. So, what is the key success factor for reconstruction? I would like to start my presentation from the mandibular defect, then I will go to maxillary defects. If we speak about mandibular defect, everything depends on the geometry of the defect. If we look at very simple linear defects in the mandible, so normally this is the body of the jaw when the chin is preserved, and then we replaced linear defect in the jaw. So it looks very simple, and we all know, because this method is very well known, so we put mini plates, fixation mini plates, and they work very nicely. They allow to integrate bone autograft very successfully, and this is one of good example. This is vascularized free fibula graft with mini plate fixation. So this method allows to reconstruct sometimes very complicated defects. Look here, very complicated defect. For example, if we have angulation defect, which is lack of tissue of upper of maxilla and mandible. So these are mini plates. Fibula grafts and mini plate fixation, it helps to reach very good results, and very frequently it happens in the cases where we can keep the branch here. Specifically in this patient, you can see sarcoma, mandibular sarcoma, very good integration of autograft. At the same time, we frequently see the defects that combine defects of the body and chin defect. And this is already difficult structure. So this is typical defect. That's subtotal defect or mandibular subtotal defect. So you see this is oral cavity tumor with infiltration in the mandibular tissue. So this is extended surgery. And we faced this trapezium-like defect. There is very simple method of reconstruction of such loss of tissues in the mandibular area. This is modeling of the graft, fibula graft, as a simple figure, like a triangle. And in a number of cases, this method allows successfully bring rehabilitation. And also we can use mini plates for fixation, because this is equal size triangle compensate the load on the angle next to the chin, and this figure appears to be very stable mechanically. And here we see the outcome 1 year post-op. Very good functional result. But still we see that there is hypercorrection. And here are some questions about the method, how to plan reconstructive stage in this patient. And we should go from simple to more complicated, where we make not the triangle, equal size triangle, but one of the size of trapeze-like. And here we have problems because this is not stable. This is not stable in terms of mechanic load, and this construction starts moving in this triangle, and we see instability of osteotomia. We see instability of osteotomia in autografts, and also instability, also myelitis, where osteosynthesis was performed, and it links to chronic inflammation with the rejection of fixation elements, and it cannot be considered as satisfactory result. Then there is a good help with CAD/CAM technologies that help us successfully resolve the issue of modeling, 3D modeling of this reconstruction and selection of plastic material. As an example, I want to show you one of the cases. Patient with previous surgery. This patient was referred to us, so they made reconstructive surgery. They used Fibula Graft, but patient came to us with osteosarcoma relapse after non-radical resection, and we had to perform secondary resection, mandibular resection, and this is our planning. We understanding that modern CAD/CAM program allow to have good precision for the rejection. And most important, then you can plan it pre-op, you can plan genian area, you can plan mandibular or maxilla area. So you make the template and main focus here on the correct angles, and we pay big attention at the stage of planning. We need template, we need pattern, and what is very important is pre-op modeling. So we do plastic material using fibula, and what is very important here is to model the angles of osteotomia in order to create a new mandible. The construction is placed here, and this technology allows to model correct occlusion, and we don't spend time on that during the surgery. We don't spend time for the improving of autograft in order to match all the fragments. And most important, technology allows to model the reconstructive plate. We know that correct fixation of bone fragments is a key success factor of any reconstruction stage. We stopped doing overhead plates because we didn't want cutting, we didn't want exposure. And here, these are one of our first experience, and in that case, the plate was shifted backwards to the posterior and backwards, and then anterior surface of this autograft is not covered, and soft tissue could have good contact with autograft. And this is very clear that we patented our solutions. And what do we have at the end after all these innovations? First, this is very good positioning of autograft in the reconstruction area. Also, it is important that this technology and intra-op modeling on the individual templates and individual cover plates allows to save time. It is much faster. And we know that if you shorten the time of the modeling, that's the key success factor, because then the outcome would be better. Here you see the residual of mini plate after the first surgery in the other clinic, but here you can see good engrafting. The bone fragments are placed correctly, And in 3 months after the surgery, they have very beneficial position in the reconstruction area. And 8 months post-op, you can see full integration of the fragments. So this is cosmetic result after the surgery. Here you see almost ideal aesthetic results for this patient. More complicated situation is shown here when we face mandibular defects that also combined with the resection of ramus and condyle. So here are some designs and one of the example. And the previous resection was performed, again, mandibular tumor, and the other clinic put reconstructive plate. So this is an old method, which was very prevalent. It allows to keep the fragment, to keep the occlusion, but it does not resolve the problem in the near future. We know that there is very frequent exposure. That is why we offered this patient to have reconstruction with Fibula Graft. One of the advantages of CAD/CAM software is the option to plan the bunch vascular bundle in the graft. And the position of the bundle, vascular bundle, and the option to control the position during the modal brings additional success. This is one of the early examples. This is the engraftment. This is construction we designed. This is complete fixation with head. And majority of the of products available there with no fixation, and also individual plate, reconstructive plate, and this is tempora mandibular solution. And you see that bone tissues, how the close contact of soft tissues is seen. This is example. This is another case with the same surgery, a little bit of different construction. Again, temporomandibular, the earlier solution. But this is example. Here on the slide, you can see early modification of joint. Again, temporomandibular without head fixation. And we stopped using it. What are the drawbacks? What are the problems of this construction? So there is very high rate of migration here of the head, and you need to perform joint reposition. So this is how it looks like intra-op. And this is the result we got 6 months post-op. To me, this is a very good result, very good and functional result. Occlusion is performed. And currently, we are working on the minimization of the metal component here of this reconstructive plate. And so we are working over the forces here in this plate in order to reduce more to the amount of metal which is needed for the fixation of autograft. And this is how patient looks like 6 months post-op. You see fixation, adapted, occlusion, good opening. And now I would like to go to the maxillary defects, and this is totally different. Totally different course, clinical course, and totally different reconstructive surgical defects. They are different from mandibular defect. First of all, this is very complicated geometry. We know that maxilla is very complicated 3D structure with very thin walls, bone walls, and reconstruction of maxilla should be sustainable, should be light and 3D comprehensive structure, which is not easy, to do. Sometimes it's really difficult to perform reconstruction of such defects, and one of the frequent reasons, because these defects, they're always combined. They could include skin, mucosa, plus bone defects, so all three in one. That is why there are very high and stringent requirements to the plastic material for the reconstruction of such defects. So this is one of the options of possible reconstructions in the maxillary defect. So this is a patient who had previous surgery, maxillary surgery on the right because of tumor. Here you see the problems. So reconstruction was not performed. So they just made the resection and rehabilitation using prosthesis. You see the problems of such option of rehabilitation of patients. Here you see that very frequently we see scarring, we see scars, but this patient came to us with relapse. And here we needed to resect the right side, right maxillary side. So we got total defect or maxillary defect, total maxillary defect. So we need to find plastic material. So there are attempts also to use fibula graft as well for maxillary reconstruction. And you can get a very good direct effect using this method, but still, method is not ideal. It is not ideal. Why? Because a fibula graft allows to recover alveolar border of the maxilla, but does not recover the defects of the anterior wall. And finally, it leads to the scarring, to the deformity, where we don't have bone. As we know, last 10 years, there is a new method to use scapular flaps for the reconstruction of maxillary defects. One of the methods we like very much. This is the use of scapular osseous muscular cutaneous free lap on angular artery. This flap is very beneficial from many positions. I'm not going into the depth of this scapular flap, but it can be hybrid, chimeric, and it can be selected in different options, including muscular part, cutaneous part, and then you can replace effectively such very combined, complicated defects. So this is a patient who again had a resection of left side of maxillar because of tumor. You see ororenostoma in the defect. So this patient had rehabilitation using ectoprosthesis with obturator. Well, this is good oncological result. Patient is relapse-free, but there is serious functional and cosmetic defect here, plus scarring deformity, also putting down of the orbit. And we went for reconstruction. We wanted to replace the defect using chimeric flap, like this, and this is the direct effect 1 month post-op. Here you see upper defect, and later on it will go for atrophy like this. And here the stage 6 months post-op. No, it's a mistake. It's 12 months post-op. It's a misprint. So you see isolated nasal cavity from oral cavity, and I think it's very satisfactory aesthetic result. So we recovered the position of the orbit. There was dental rehabilitation as well. Yes, there is a cosmetic defect after this reconstruction. So there is a bit more bone here that can be corrected, but I want to talk about it here. So such defects due to the absence of pre-op 3D modeling. So in that case, we didn't have it. We didn't have 3D modeling. It was just analog intra-op modeling. And I want to show another clinical example where we used 3D digital modeling. In this case, we performed resection of the upper jaw and simultaneous mandibular reconstruction using scapular flap. So this is CAD/CAM technology. Beside planning, correct resection in such patient, we can visualize the defect. We can position the graft. It's very important because in maxilla we need to model angles and different planes and to meet the anatomy. So the graft should replace alveolar border, also anterior wall of the sinus, etc. It is very important to plan and produce resection template. And you cannot avoid spending time on excessive measurement in patients during surgery because it complicates the harvesting and prolonged surgery. Normally, in such patients, the inferior defects recovered via individual grafts, for example, from titanium, so implant, titanium implant, and it helps to model anatomic specificity of the structure next to the posterior and lower orbit. This is complicated modeling, and we did it during surgery. So this is how it looks like. This is infraorbital position of the graft. These are early grafts. We produced at earlier stages, but currently we modernized our construction. And here you can appreciate maxilla and orbital zygomatic complex. Now the construction is much lighter, no more metal access. And this is how patient looks like 3 months after such surgery at the stage of rehabilitation. You see adapted space here and a very satisfactory aesthetic result. You see reconstruction of hard palate, and hopefully this patient will look very nice in 8 to 12 weeks. We see opening of the eyes, you see opening of the mouth in a good volume, and the patient is ready to perform dental rehabilitation and implant positioning. And the most important is that we have bone structure. So wrapping up, I would like to say that today we have a lot of different designs in reconstructive surgery to perform different stages and replace different defects. But very frequently, these technologies, they are difficult in routine practice. And in fact, they complicate surgery as it is. That is why today I believe that main efforts should be focused on the simplification of technology of modeling. We need to simplify the technology. And as an example, I would like to give you this picture here, space-related technologies. We know that people reached moon long ago, and in 1970s, at the beginning of 1970s, people managed to touch the moon. But now, having this 50-year experience of traveling in the space, we yet do not have the technology of mass space tourism. So we can do it, but we can do it exclusively, not massively. Why did it happen? Because the technology of space tourism is not possible, because space technologies appear to be very costly and complicated, and we stopped using them. Too expensive. And now I believe that we should go the other way. We should simplify the technologies and digital solutions. They are mainly simplifying. And as soon as they are simplified, they can become massive. And then we can improve life of surgeons and improve functional results of our patients. So I believe that future belongs to simpler technologies that give us simple and effective way. By the word simple, I mean easy. Easy and fast. Intra-op to model autograft, to do 3D modeling and perform effective and successful reconstruction of such difficult maxillary and mandibular defects and maxillofacial surgeries. Thank you very much for your attention.
Dear guests, dear speakers, do you have any questions we need to discuss Professor Mudunov's speech, or we can move on?
Yeah.
Any questions, or shall we move?
Thanks a lot, Professor Alimodov, for very excellent presentation. My question is, when you use the titanium plate, mini plate, and reconstructive plate, used mandibular reconstruction with the fibula, after operation, maybe during operation, after operation, stable, not very stable with the use the mini plate. So how to regulate and how to selection mini plate and reconstructive plate? This is a first question. And the second question, as you know, the case SCC, very extensive for tumor. When you remove the tumor, primarily use the fibula osteomyoclonus reconstruction, the larger defect. After operation, in my opinion, you use the radiotherapy. How to control osteonecrosis.
Спасибо большое.
Thank you very much. This is very important. Two questions. The first question about stability of fixation with mini plates. I tried to show some illustrations in my presentation. We believe that future belongs to reconstructive plates in case of big mandibular defects. And it should be individual reconstructive plate, not the standard fixation plate that you have to turn around, but individual titanium plates. This is our vision. On the one hand, it saves time in terms of modeling. On the other hand, it helps to reach good stability. Individual plates give good stability because we know that configuration of mandibular defect will influence the stability. You are absolutely right. And we believe that only individual mandibular reconstructive plates allow to reach very good stability. And we should stop using a lot of mini plates, not many. You don't need many, because mini plates could give stability in small linear defects. It works okay. But if this is massive tumor, if this is complicated 3D defects, then we prefer to use individual, because if you take mini plates, you use too many, and they're everywhere in the wrong positions, and they are not in the places where they should be, where there is space. So we think, oh, another plate, it's plus and plus, but it's not a solution. I think in the massive defects, the biggest advantage are individual, but the other thing is that you need to produce them with minimal titanium, minimum metal, and we are working on that, how to minimize the metal there. Now, your second question, radiotherapy in patients with massive advanced resections and tumors. Yes, we have experience of radiation therapy of such patients. To my understanding, the most important method of prevention complication is adequate circulation, adequate blood circulation. There should be good blood circulation, and there will be good tolerance after radiotherapy. And I have some ideas about it. In Russia, historically, when we treated oral mucosal tumors, we use pre-surgical irradiation, pre-op irradiation, and possibly for such patients it's the best way. First, you do pre-op radiotherapy or pre-op chemoradiotherapy, and then you go for surgery, extended surgery. And this is how we will get the same result, the same combined treatment, but in the other order, without excessive influence of radiation to the graft. Thank you.
It means for your cases, like you introduced, just pre-chemo and pre-radiotherapy. My question is, after how many times after radiotherapy you can continue to operation?
Currently, in our clinic, we use this protocol. If there is a big maxillary tumor, patient get pre-op radiation. Pre-op radiation. Patients who have big oral cavity tumors. So maxilla, pre-op radiation. Oral cavity tumors go first for surgery and then chemo and radiotherapy, post-op chemoradiotherapy. You ask me about interval. The plan of treatment depends on histology of the tumor. Number of patients I showed had tumor sarcomas. Tumor sarcomas, they did not require irradiation, neither before or after surgery, because sarcomas, they are not sensitive to radiation. But In
Yes.
other cases I showed, yes, we had squamous cell carcinoma and they had radio. One lady with maxillary defect, she had radiotherapy before the surgery. Another female patient with mandibular defect, she had radiotherapy post-surgery. Our safe interval is about 4 weeks post-surgery, 4 weeks post-surgery, and there are many patients like this. Patients who after mandibular reconstruction get radiotherapy post-op, the safe interval is about 4 weeks. We believe that this is safe. This is safe interval, and this is safe method for the graft. Thank you.
Thank you so much for your answer, my question.
Спасибо. Пожалуйста.
Спасибо, Ali Muradovich.
Thank you very much, Professor Mudunov. Many thanks for a very interesting presentation. And now we go to the next presentation, and this is Professor Swen. And this is a presentation to use individual grafts and constructions, reconstruction of maxillary defects using individual implants made of polymer materials by 3D printing.
Okay.
You're welcome.
You're welcome. Please start. Oh, you need to make it full screen. Please make it full screen.
Ali Mudunov invited me. Mudunov invited me, and I'm honored to hear his wonderful speech, giving me lots of inspiration. My topic is maxillofacial defects, reconstruction using patient-specific PEEK implant. What happened after jawbone loss, mainly including facial disagreement and functioning disability, eventually quality of life will decline. Now let's look at the development of surgery in jaws reconstruction. We went through similar reconstruction with the development of digital medical technique. We can achieve accurate reconstruction. In the future, the reconstruction should be towards refinement. These are goals of maxillary reconstruction. In short, including appearance, midfacial in buttress, and dentation. Let's review the history of functional maxillary reconstruction. Around 2000 year, fibula, scapula, and DCI were used for maxillary reconstruction. In our department, we went through soft tissue reconstruction before 1997. After we used the bony reconstruction, up to now, we achieve simpler and exquisite bony buttress reconstruction. Between 1997 to 1999, latissimus dossier and serratus anterior flap were used for James Brown class 3 defects. You can see this slide. Short-term results is good, but the long-term result is anisphorous. What's the reason for this? It may be related to the lack of heart tissue support. So, establishment of midfacial bony buttress is very important. For this, we design Chinese flap and a titanium mesh with a steady model for reconstruction. We can see this slide. We just use three-dimensional titanium mesh with the Chinese flap folding, and one part closure the nasal cavity, and the other closure the palate. Early stage, we can achieve good results, but fistula will happen in the alveolar region. So we were thinking the reason maybe lack of bony structure. So since 2001, we first proposed and described a combination of fibula osteomyocutaneous flap and titanium mesh for reconstruction of James Brown class 2 to 3 defects. This video is about our design for reconstruction of James Brown class 3 defects using fibula to establish the horizontal and vertical buttress, using titanium mesh to support the eyeball and restore the anterior wall of maxillary sinus. In order to verify the feasibility of our design, we use three-dimensional finite element analysis. The result of biomechanical analysis of three-dimensional finite element models of neo-maxillary are shown in this slide. Finally, we find stress distribution pattern and a stress vector diagram of neo-maxillary reconstructed with three-segmental fibula were similar to those of normal maxilla. That is to say, our method with three-segmental fibula and titanium mesh is proper to maxillary reconstruction. This patient just show you with my new technique to reconstruction, maxillary reconstruction. This patient with ossified fibroma in maxilla appeared facial swelling and global dislocation. First, we did a virtual surgical planning to determine the resection margin and perform the surgery according to our design method. These are the cutting guide and the reposition guide. Titanium mesh and prevent the plate. And the titanium mesh and the plates were prevent with the still mode. Tumor was totally removed. This is a defect after resection. So for this larger defect, how to use the method? We just use the three-dimensional titanium mesh with fibula three-segmental combination. And you can see expose the tumor, remove the tumor, and put the arrange the fibula fixation, and finally we can see the patient pre-operation and post-operation and intraoral. Finally, implant rehabilitation. We can say it's really functional, accurate maxillary reconstruction. This young lady suffered osteosarcoma in the maxilla. 2 years later, after total maxillectomy, this lady has a very strong urge for maxillary reconstruction. So we design in the same way fibula with the PEEK materials. That means the PEEK implant represent the and the different the titanium mesh. So this is a procedure of the operation. Incision in the incision and exposure the defect. We used PEEK materials and a total dissection around the eye bone. Like this, we put the fibula segmenter and with the PEEK. After we use the receptor vessel is temporarily artery and then vein. So you can see, finally, we can see we can be achieved good results. So in our opinion, achieving real ideal joint reconstruction needed three main requirements: aesthetics, functional, and reasonable. That means the technique may be reasonable. So maxillary reconstruction and maxillary defects have a complicated three-dimensional structure and are often combined with eye bone damage and or communication with the nasal cavity. Therefore, the requirement for modern implants are more concerned with sharp adaptability and biocompatibility. Fortunately, PEEK emerged in 1978. PEEK was introduced as an individual the implant. 2011, application in domestic medical institution. So PEEK implants offer two distinctive advantages. First, they are translucent to X-ray rays and non-magnetic, so they don't create artifacts in CT and MR image. So very useful for the malignant tumor follow-up. Second, PEEK is a non-conduction, asymmetric, and lightweight, providing patients high comfort. I just show you the first case is a patient of a vein malformation in the superior orbital bone. You can see this side. So first we did a virtual surgical planning to determine the resection margin and designed the shape of the PEEK implant. So this is a procedure of operation. We used bicoronal incision exposure the tumor and protect the nerve and used the cutting guide resected the tumor. This is just to show you the defect of the bone. We used a PEEK implant and a fixation. So finally, this is a picture in the patients. You can see this side, pre and operation. We can be good results. And there is no nerve damage after operation. The second place, the patients is also nerve venous malformation in the sigmoid. You can see the facial swelling. Using virtual surgical planning to determine the resection margin and designed the shape of the PEEK. And also designed the cutting guide. The operation using hemicoronal incision to expose the tumor and protect the facial nerve. Totally expose the tumor and totally remove the tumor according to cutting guide. Finally, we put the implant PEEK and a fixation after operation. So this is the comparison between pre and post-operation. We can be achieved good results. This patient is diagnosed as fibrous dysplasia. Based on our observation of part of our patient with fibrous dysplasia or ossifying fibroma in the maxillary. Also, the lesion gives rise to facial swelling, especially eye bone displacement. It doesn't always involve the alveolar ridge. Teeth show minimal displacement with almost normal occluse relationship. So for this kind of patients, what we do? We can choose totally remove the tumor, and we can large portion of the maxilla remove and preserve the alveolar region. So we designed a novel surgical technique for treatment of this type of mass in maxillary dry-like resection. That means dry-like resection. In this animation, just a slide just to show you this animation. Tumor resection and maxillectomy were simulated on the computer. Then tumor resection and maxillectomy were performed according to the virtual surgical planning and with bone cutting guide. For patients with maxillary defects, titanium mesh was fixed to alveolar ridge and residual bone. That means in this kind of operation, we from complicated operation goes to the simple. And in the injury decrease, time, cost, complication lower down. So reconstructive reconstruction, resection, and become to the conservative functional surgery. This is a virtual surgery planning and the desired peak implant. A cutting guide made. During operation is this slide just show you process of the procedure of the operation. Exposure. We use the Weber Ferguson incision combination with the hemicolonal incision. Like this, we can very easy to show the defect. After remove the tumor, we put the peak implant. This slide just show you before and after. We can be a good results compared to pre-operation picture and post-operative picture show the good appearance. Finally, post-operative eye position had come back to its original position as the same level as the opposite eye. The comparison of exophthalmos degree and the vertical position of eyeball showed significant improvements between the pre and the post-operative operation. Orbit volume also showed significant improvement post-operation. Since 2018, 9 cases were performed primary reconstruction with peak, and all of them obtained good aesthetic and functional results. This is another patient of malignant inverting papilloma. After total maxillolectomy and reconstruction with temporary myofascial flap in another institution, after 2 years, the patient wants to rebuild the deformity of facial depression and anosomos. This is our design. We use peak material to restore the orbital volume and the shape of the maxilla. These are surgical procedures. During the surgery, the ophthalmologist recanalize the nasal lacrimal duct. So finally, picture after surgery show the fine appearance. We recover the level of the eyeball. Welcome to our ward. This is a nice people's hospital in our ward. And our department is the biggest oral cancer diagnosis and treatment center in China. In our department, we have nearly 300 beds. The only 2 academicians in stomatology in China. Only a set of surgical treatment, radiotherapy, chemotherapy, and a basic research in one in China, like head and neck hospital. Thanks for your attention.
Thank you, very interesting as always, and a lot of new information for all the interested people who are with us today. Ali Muradovich, какие-то вопросы вы хотели бы обсудить или переносим?
Dr. Mudunov, do we have any questions, or shall we have Q&A session at the end? Thank you very much, Professor Swen, for very interesting presentation. Fantastic results. You can proud these results, and my congratulations. These are very good results. I have 2 questions. My first question, we saw that there were lots of maxillary patients, maxillary defects, where you use implants for the reconstruction. And we know that very frequently, almost in all the cases, in case of malignant resections, there is a defect in the nasal wall, lateral nasal wall. So it appeared to be we put the implant, it can be titanium or PEEK. We put it, we cover it anterior with muscular cutaneous flap, and in the bottom is mucosal flap, but medial portion of the implant is open in the nasal. In this case, don't you see any infections in the implant because the nasal wall is open with further instability and infections, lateral nasal wall, which is not closed? So that's my first question. I hope it is clear. My second question, you have experience of both titanium and PEEK in long-term results. What is better, PEEK or titanium? So first question about nasal wall, and second question, what is better, PEEK or titanium? Thank you. Hope the question is clear. I speak slowly.
Thank you. You are asking my question. First question, impossible. When you recover the PEEK implant, it's nice. If soft tissue not enough to recover, you can just residue the small ward, just like the drainage for the 一个下面 infranasal cavity. Like this, it's okay. In our patients, several patients like this, the long term, we can be a good results. No more very big complications. And the second question is just PEEK and titanium mesh, which one is the best? Is better, right? Yeah. In my opinion, before we just use the titanium mesh. So titanium mesh for our case is a lot of patients is a malignant tumor. So if you use the titanium mesh, not really careful, especially superficial, and protect very well after radiotherapy exposure, the titanium mesh. So titanium mesh and PIC implant, I think it's the same. It's the same place. It's the same complications. So in our experience, if you use the PIC or titanium mesh, you can be resolve several methods. So you use the free flap, you use the fibula flap, you can use the soft tissue cover the titanium superficial titanium mesh. The PIC plants, it's the same. It's the same. Yeah. And the dissection very extensive, like this, no tension, no stress. This is my experience.
Спасибо, профессор Суэн. Спасибо. Очень
Thank you very much, Professor Suen. Very interesting. Thank you very much for the questions.
Thank you very much. This is very impressive, very interesting. Now it's time for Jiang Laoshi to introduce his topic, his master's. Please welcome.
Okay. Is it okay?
Negative, no.
I will, okay, share the screen, right? Share the screen.
Green button, share the screen.
Good.
Yes, it's
Now
coming.
you open the PPT. Okay, good.
Now full screen.
This button. Yeah.
Perfect.
Good, right?
Perfect. Congratulations. You can
Thank
start,
you.
please.
Okay, so it's very happy to be here to share our experience with Professor Sun instead of the Shanghai Nice People's Hospital. I'm from another department, but we also involving in the oral maxillofacial surgery. So we are more focused on the technique and the therapy for the plastic or reconstructive surgery about the trauma and the prosthetic surgery. So my topic will be the computer and the digital guided CMF, PI, and PNR surgery. So I will pay more attention and focus on the technique more than on the specific cases on the oncology. So when we're talking about the surgery in the ancient times, we cut and then we see where is the lesions we can find. In the past time, I mean, 15 or 20 years ago, we have 3D CT scan and the other image. We can see the image before we cut, but we still have to have a lot of big incisions before we cut and or during our cut. And the aim of the cranial maxillofacial surgery in plastic and the reconstructive surgery procedures, our focus, our aim is to getting more minimal invasive and the precise and the safe procedures. So the computer, or we can say digitalization, or we can say image guided surgery can help us to solve these problems. And it has been about 15 years progress all over the world. And I want to summarize 4 main techniques that can help us for the surgery. The first one is the software-based surgical planning and simulation, and someone called them virtual surgery. And the second one is, it's very hot recently, it's 3D printing surgical guide, and the 2 professors has mentioned a lot before. And the third one is the operative navigation support. That's navigation system or navigation technique. And the fourth one is robotic surgery. I think these four main techniques then will influence a lot in our routine work or in our daily treatment. So I want to describe more by details from one technique to another technique. The first one is the surgical planning. That's virtual surgery. We are using that quite often. And the two professors before, they said using different software, and we are now using this, such as Surgicase from Materialize from Belgium, and we can use the Julius from Germany and Amira, blah, blah, more. And these are the workflow that we can get the 3D model, and then we can do the surgical planning and the prediction. We can get the CT scan. We use specific software to get the 3D reconstruction models, and then we use a lot of different guides or different methods to do the surgical planning. And these are the usual work in our clinics. We have the deformity cases, and we have trauma cases, and we have the tumor resection and the reconstruction. For example, we have a sample. This is a very severe trauma cases, and with the software, we can very easy to get it all the surgical plan pre-simulation, and every doctors can see clear on the screen, and you have the prediction of the results of your surgery. And this is another one that we are using quite oftenly. That's tumor cases. We define the resection area, then we make the cutting guide, and we design the reconstruction method with fibula or with iliac bone. Then we can put the pre-bending plates, or we also can use the 3D individual plates nowadays. And we are very hard to do something about the soft tissue simulation. I think all the doctors has met the problems. We can define the hard tissue simulation very well, but the soft tissue can be flexible. So it is not as precise as we simulated before. We are using now in our department, we are using a 3D, we call it 3D MD system. It's something like a 3D camera, several cameras, then can provide an accurate surface of the image. And it can also evaluate the volume of the volume change, or maybe the volume you need for the soft tissue reconstructions. I just describe one simple cases. It's left facial microsomia. What we want to do is to do the lipo injection for this patient. But in the past time, we have no idea about the volume change or the volume we needed to reconstruct the defects. But we use the 3D system, then we can calculate, not as precise as that much, but we still can do something about the soft tissue. It's very similar if we are using the flap. We all have to experience, we maybe usually will do a more bigger flap to meet the requirements, or maybe some flap is not that necessary. But for this patient, we just calculate the volume and we put the equivalent mass of the fat, then we can reconstruct the defects more precisely. And we are doing this kind of research now, not only the soft tissue, but also we use the movement for the mandible or for the maxilla. And we want to simulate more about all the tissues and also the movement. That is so-called 4D. And the second technique is the 3D printing. I think there are three main techniques for the 3D printing we are using now. The first one is the RP model. The second one is the surgical guide, and the third one is surgical implant. The RP model that's in our department, we use that, I think, 10 years or 20 years ago. At that time, this is the case I did 20 years ago. It's a Church-Collins syndrome, very severe deformity of the cranial and the maxillo and the mandible bone. And that time we have no software, we have no navigation system, everything. But we only can get the 3D model from the data from the CT scan. So we spent 1 day to do the model surgery. It can be used nowadays. It still can be used now. And during for that model, we do the model surgery by ourselves, by the surgeon themselves, and we do the procedures as we did that on the models. So that's the procedures. And finally, we get good results, but not that good. But it's still okay. I think it's 20 years ago. And nowadays we have a lot of surgical guides that is mentioned by the two professors before. So in our department, we have a 3D printing center. We have the 3D printer, we have 10 machines of the 3D printer, and we can do the printing guide and produce them by the engineering or by ourselves. And for example, this is a quite common case. It's amyloblastoma of the left side. We are doing the cutting guide for the tumor and also the cutting guide for the pre-shaping of the fibula. Then we get very good results only by the cutting guide. And the third technique for the 3D printing is the surgical implant. We are using a lot of, as Professor Sun said, he's using the PEEK. We are using the PEEK also. And this is a case that is, the gentleman has an infection, I think it's for 15 years. And a very complicated 3D shaping defects on the left zygomatic bone and the maxilla and orbital floor area. So for this patient, if we only do the osteotomy and do the reconstruction, I think it's too complicated. And we are designing for for the material that's made by the HA. This is a HA materials. Then we simply put it on the defects. Then we check with the navigation system, and we get the very good profile for the patient. The patient is very satisfied because the procedure is very easy. And this is the second person. It's also the post-traumatic deformity after trauma for 1.5 years, and there was defects on the midface, and we use the PEEK also, and we also do the osteotomy for the Lafort 1 to change the occlusion relationship. And this is the pictures during the surgery and all the procedures. We do the Lafort 1 osteotomy, and we correct the occlusion. So this is the profile after the surgery, and this is the occlusion relationship after surgery, and this is the CT scan. And the third materials we are using for 3D printing materials is for the titanium things. This is a patient, is the osteonesis, very common case, maxillar hyperplasia and the mandible hypoplasia. We are using all the templates, I mean the surgical guides, and also the fixation plates using the individual customized 3D printing technique. So these are the surgeries, doing the surgery with the maxilla for the cutting and also for the fixation for the maxilla. And this is the ramus osteotomy, use the cutting guides, and we fix that with the individual customized titanium plates. We also do the chin plastic, the genioplasty. We are using the cutting guide and also the fixation plates using customized one. This is after surgery, and the X-ray from post-operation. So we are thinking about, this is the question the two professors talking previously. So which is better for the materials? I think nowadays we can use PEEK, we can use HA, we can use titanium. Every materials has their specific character. I think we should conclude an idea just from a lot of view of points. For example, we should evaluate their biocapacity, their infection rates, their radiology resistance. And from the conclusion, we cannot say which is better, but we should choose their specific characters to meet the surgery's requirement. And the third technique is very important, I think, nowadays, and in the recent modern digital things is intraoperative navigation system. And I want to have a brief introduction about the navigation that we are using, the tracking system that is we previously used in the airplane or in the driving system, right? So it's a 3D real-time vision, and it can be introduced to the medical use within maybe 10 years. It's a tracking system. And for the clinical application for the surgery, it has been widely used in a lot of areas. The first area is neurology and orthopedics, otology, radiology, general surgery, and oromaxillofacial surgery, and so on. And these are the samples for the orthopedics use and for the neurology and the other area. The advantage of the surgical navigation, we concluded, is it can get minimally invasive procedures, control of the surgical approach, and protect of the border and the protection of the neighborhood structures, and get greater surgical accuracy. And the current available system in the world, they have such as 4 or maybe 5 systems, mainly from the Europe or from the US. And this is the data flow. So this is just finished from the planning and the simulation of the surgical plan. And then we use the navigation system to tracking the instruments and also the position of the patient. And we show that in the monitor, we can track all the things and control the direction and the deeps in the surgery. Then we can get more, get good or better accuracy for the surgery. So in our department, we have 3 different systems. One is from BrainLab, that's from Germany, and one is from Stryker from Germany also. And we have set up our own navigation system. We call it AccuNavi. It's only for the CMF surgery. And within 7 years, we did more than thousands of the navigation surgery that's guided by the navigation system. And we also publish the experience about the application and the indication in the CMF surgery with the guidance of the navigation system. So we can see all over the surgeries we did in the oromaxillofacial surgery, such as TMG, trauma and the post-traumatic deformity correction, CMF plastic surgery, orthodontic surgery, tumor resection and the jaw reconstruction, and even the foreign body removal. We can use the help with the navigation system. And I want to describe or demonstrate some cases of different specific use and to show you how the navigation system can help us during the surgery. The first one is the Tmg surgery. We see this child with the ankylosis on the right side. If we did we call it condylectomy as usual, we cut it from here. And you can imagine the result about the patient. The occlusion will be changed, the growing skeleton will be stopped, and the facial profile has been changed a lot. But we are using the modern technique. We just want to move the ankylosis area here, and then we want to reserve the small condyle innerly. And we use the guide of the navigation system during the surgery. We can see from this tube. So we cut the bone and we guide with navigation system. We carefully preserve the inner parts and we remove the outer part. You see, from this is the image during the surgery. Okay, this is the final result. See, the patient has been good mouth opening after surgery, and occlusion relationship is normal. And from the CT scan, we can see we preserve well with the condyle, and we remove all the ankylosis area outside. The second one is the trauma and the post-traumatic deformity correction. This is the regular cases. I think the key point, this is is multiple fractures of the facial area, and malocclusion, big volume of the orbital floor and the skull bone fractured. And this is the simulation before the surgery, and all the procedures has been guided by the navigation system. And the important things for this patient for the navigation system is the orbital floor. So we really meet a lot of problem, even the trauma cases, or we do the reconstruction of the maxilla. It's hard to define the place of the orbital floor. And this is the profile and occlusion after surgery. And this is the CT scan after surgery. And the average accuracy is about 1 mm. It's very precise. And the third application in the area is tumor resection and the jaw reconstruction. And I just mentioned some cases. The first one is still the child. He suffered from the swelling of the left face for 1 year. And from the CT scan, we can see a big mass in the cranial base and also in the deep facial space. And so for this patient, it's very important you will get the precise diagnosis before the surgery, I think. So how to get the diagnosis? We are using a navigation-guided percutaneous biopsy. That the final result is sarcoma. So very easy procedures, very precise procedures, we can get the diagnosis. So this is the first advantage for the tumor cases. This is the second one for the amyloblastoma, for the mandible and the reconstruction. And this is the cutting guide. The advantage for the navigation system for this patient is we can control the width of the condyle place for this one, and we can control the angle place for the mandible. So that's very important when we mention about the mandible reconstruction. So this is the final result. The condyle height and the location is very good. This is the occlusion. And the third case we cannot say it's an oncology case, but a little bit more likely to be that. It's a fibrous dysplasia of the right skull. So that patient is still young, but she complains about the impaired vision, that's double vision, the deformity, and she suffered from a headache. So we combine with the neurosurgery, we do a contouring of the skull bone according to the middle position, and we guide from the navigation system. So we remove the deformity and we reconstruct that with the titanium mesh. So this is the cases, this is the profile and the CT image after surgery. The vision and also the symptom has been changed a lot for the patient. So this is the last case. I think it's quite interesting. It's foreign body removal. This guy has been suffered from the gunshots, and we can find a lot of bullets in his body. And in the oromaxillofacial area, there is a bullet inside, and it's very near to close. It's very close to the artery, and it's very dangerous. So we are talking about how to remove that intraoral or extraoral, and the most risk thing is to preserve about the artery. finally, we use the navigation system, and we tracking the instruments for the surgical forceps, and we remove that intraorally with very small incision. And during the half an hour surgical time, we remove the foreign body. It's a bullet here. You see, it's very easy and with low, very minimal invasive procedures. Okay, so we still have tried to combine several techniques. For example, the cutting guide, the navigation system, and the endoscopy. So I've mentioned one case that's the patient has suffered from deformity of the maxilla and the mandible, and also we find that there is a condyle osteochondroma at the right side of the condyle. You can see here. So the usual procedure, we will open that with the extraoral incision, and we have a very big injury for the patient. But with the guidance of this digital technique, we simulate that with the osteotomic surgery. And during the surgery, we are using a navigation system to define the place we want to cut. And we're using the endoscopy to make sure if you are cutting the right area. So only with the intraoral incision, we remove the tumor. And simultaneously, we do the osteotomic surgery with the maxilla and also the mandible. So this is the final result for the first stage. And the second stage, we use some contouring of the mandible for the mandible angle and also the body with the cutting guide. And then this is the CT scan and the X-ray from after the second stage surgery. So finally, the patient has been changed a lot, even the profile and also the occlusion. And there is no scar in the face. So this is no scar on the face. Okay, the last technique I want to show you is the things about the robotic surgery. So we are thinking about if maybe with the help of the robotic surgery, all the surgeons may be retired, but we do not like to do that. But I still want to mention that they are very useful nowadays in the cranial maxillofacial surgery. The application of the robots, medical robots in the oral maxillofacial surgery nowadays, that's internationally, we have Defect things. I think everybody knows the Defect method for the CMF surgery. It can be used the tumor resection for in the oral and the pharyngeal area, or maybe the tongue base. You see from this video, it's cutting with the Defect and to cut a tongue base tumor. And some guys using the Defect to do the microsurgery. That means, for example, the vascular connection and the other things. But the shortage for Defect is it cannot do the hard tissue surgery. Okay, so the dental application, we are oral maxillofacial surgery. We care more about the dental things. The only international business product is from United States. It's called Yomi. It's an implant machine for the robots. And in China, a lot of universities, some of the universities, they are doing the research work. But all the products are still in the lab sample machine stage. For example, from Peking University, we can see the machine is doing the implants, and also from the Air Force Military Medical University, they have also the sample machines. And in our hospital, in our group, we have the similar research work now, and we're designing a cutting machine. So for this video, we are using the robots to do the osteotomy for the deformity, and it can also be used for the mandible lectomy and the other things. And what is most interesting things is our machine can have a feed force back, then let all the operator knows how many force you meet during the surgery, and we can control the feedback things and to make the machine or make the robot more safely when we use clinically. Okay, at last, I want to summarize the whole things about the digital surgery. So we have demonstrated a lot of advantage, and still there are some limitation, or we can say it's a disadvantage for the digital technique or digital guided surgery, such as it takes long time if you want to prepare the patient. Not as normally we just have very short time to get the pre-surgical preparation. And the second one is we still use special machine, and someone is very, I think it's expensive and not that cheap. For example, the robots, and still we need the special machines. And the third things I think is very essential. It's very important for the young doctors, because young doctors always think, so we have a lot of new modern technique. We have high grade machines, so I can do the surgery as good as the professors, but that's wrong. So the additional learning curve of the skillful, basically surgical technique is still needed. So that's the words I want to say to all the doctors or the young doctors. They want to do to be a professor, or they want to do more precise surgery in their future. Okay, that's all for my lectures. Thank you for your attention.
Thank you so much, Jiang. I think some extraordinary information here today. And Ali Muradovich, у вас есть вопросы какие-то?
Dear colleagues, thank you very much, Professor Jiang. And Professor Mundunov has one question. I would like to thank Professor Jiang for very comprehensive and brilliant presentation and very good surgical results and reconstructive results that he has shown in his presentation. We see how advanced is Chinese medicine. We see how advanced technology is in Shanghai Nance People Hospital. I have a question to ask. Right now, we have a lot of different instrumentarium, digital technologies. What is the process of education of young doctors in your hospital? Because you mentioned learning curve. So what are the educational algorithms? Thank you. Speak up about it.
Okay, thank you for your questions. I want to ask, you mentioned about the young doctors, the medical system of the young doctors, or you want to ask the learning curve for the digital technique? I think I can answer the both. I can answer the both. For the young doctors, for example, in the department of oral maxillofacial surgery, they have very long learning curve. First of all, they have a resident training, right? So after that, they have attending doctors training and associate professor and then professors. Around, I think around 10 to 15 years, they can be a professor and they can be a doctors, then they take in charge all the surgeries. And for the digital technique, what I mentioned nowadays, and all the young doctors and the postgraduate students in our department, they learn from the first beginning with the surgical simulation. And all the young doctors, they can perform the software, because the software, and you can very easy to download from the internet, or sometimes the 10 or maybe more computer you can set up. You can set up the software. So all the young doctors and the postgraduate student, they can perform the simulation. And then if you want to use the navigation system, I think usually it takes 1 or 2 years, only for the technique. And the other things is you should still know how to perform a surgery. So we just combine these two together. So it still have a very long learning curve for the young docs. I think it's the same in Russia, right? Thank you.
Спасибо, профессор Jiang.
Thank you very much, Professor Jiang. Well, Shalva, we have 2 questions in chat, and we already answered the first question, but we can ask second question. You mean about the peak? Yes, you can see question in the chat.
Question is that are there any comparatively efficacious materials as PEEK which are used or may be used in maxillofacial reconstruction right now? And are there any comparative studies about the utilization of this kind of materials?
Professor Sun, you first. 下我的意思就是，我们现在有没有一些比较研究，就是说这几种材料的比较研究？
还没有，在未试过。
Yes, very good. So we are talking about the evidence-based treatment or evidence-based medical things. We are trying to set up some comparative experiments or study about these materials, but still now we don't have, just as Professor Sun mentioned that. I think that they have 2 reasons. The first reason is the PEEK material or the titanium mesh or even HA, they have very different characters. So that means maybe they have different indication. So if we only choose one indication, for example, the reconstruction of the maxilla, maybe it's fit for PEEK. It's not fit for HA, right? And even more, they have very specific difference. For example, the titanium mesh, they do not have volume, right? But the PEEK have volume. So it's not easy to compare them in the same control group or experiment group. I think it can only be compared in the aspect of the materials itself. We can compare the materials, or maybe we cannot compare the indication for the reconstruction of the jaw. I think maybe this is the difficulty. But we are trying to do that. That's true.
有一个很大的问题，太往不是特别满意。
Спасибо тем, кто
Thank you very much, dear colleagues, for your interest. Many thanks to those who sent the questions. Professor Mudunov, please take the mic. Well, I would like to thank our distinguished colleagues from 9th People's Hospital in Shanghai. Today, they made brilliant, fantastic presentation with extremely interesting and difficult cases, very different indications, different digital methods used in 9th People's Hospital. And once again, we see the evidence how advanced medicine is in modern China and how highly qualified care is provided to the patient in Chinese People's Republic. And I would like to congratulate our colleagues from 9th People's Hospital in Shanghai with such advanced results. Also, I would like to thank them, Professor Suen, Professor Jiang, and the teams for finding time to participate in our morning conference. or afternoon conference, better say, for China time. And we would be happy to continue our cooperation, and I believe that would be very fruitful cooperation and collaboration in the future, because long-term friendly relations between the countries are extremely important. And hopefully in the near future, as soon as we kill COVID-19, and I'm sure we kill it one day, as soon as we eradicate this pandemic, we will be able to meet personally, to exchange working visits from Russia to China and from China to Russia, to establish future plans for the cooperation and development, experience sharing, and I'm pretty sure that we are expecting bright future for our cooperation. So many thanks for your interest, for your time, and for your contribution. Thank you very much, Professor Mudunov.
Any final words? I, from myself, am very happy to see you, and I'm extraordinarily happy that we could arrange and the connection didn't fail and that everything was okay. So I think the start was not bad, and we have place to progress, place to continue. Thank you very much.
Thank you. Yeah.
Okay.
Thank you.
Okay.
And last, I want to thanks for the interpreter. I think she is very good language speaking, and also I have one question for the interpreter. Okay, the lady, you are here, right?
Yes, I'm here, of course.
Yeah, thank you very much for the interpreter and the terrific, perfect translation for the medical term. So your background is from medical things or from oral maxillofacial surgery? Because you are quite familiar with the medical term of our area.
I made my PhD in biochemistry in Sweden long ago. I'm not a surgeon, I'm sorry.
But you are perfect. You are perfect. Thank you a lot.
Thank you very much for your compliment. Thank you very much. Have a good day and goodbye.